Hi everyone, our subject today is learning disability in pediatrics. Basics. Learning disability are a group of disorder characterized by unexpected and sustained difficulties acquiring and applying academic skill, including reading accuracy, reading fluency, reading comprehensions, written expression, mathematical calculation, and mathematical problem solving. Academic achievement must be substantially below the level expected for age and not attributed to intellectual disability, neurologic or other disorder, lack of schooling, psychosocial factors, economic disadvantage, or major sensory problems. Learning disability have neurologic and genetic roots. Reading disability is the most frequent diagnosed type of learning disability and is typically characterized by impairment in phonologic processing and or orthographic coding skill. Children with math disability show procedural, retrieval, and number sense deficient. Early intervention improves outcome. Risk factor. Learning disability are familial and moderately heritable. Risk loci and genes have been identified for reading and language disorder. Apparent neural migration hypothesized as a principal pathophysiology. Genetic contribution increase with the high level of parents' education. A biological gene by environmental interaction. Environmental factors include prematurity, low birth weight, prenatal nicotine or alcohol exposure, infection, and traumatic brain injury. Symptoms and clinical findings suggest learning disability. Child has experienced a delay in language development or has difficulty understanding language deposit normal hearing and vision. Child has difficulty following direction. Child has difficulty learning letters, numbers, and colors. Child has struggled to read, grasp math concepts, or write in comparison with peers. Letter reversion, B, D, inversion, M, W, transposition, felt, left, substitution, house, home, or confusion or arithmetic sign persist past peers. Child avoid readings aloud, writing, or homework. Child or parents is frustrated with the child's academic performance. Parent perceived child is lazy in school. Child is perceived as an underachiever. Classroom behavior or inattention has become a problem. Other family members have experienced learning difficulty or did not complete high school. History. Question when and how does the child fails in his or her daily academic pursuit. Significant learning disability typically impact only school activity and are often limited to one skill area, such as reading or math. Children with attention deficit hyperactive disorder typically show problems in multiple settings: school, home, extracurricular, peers. Children with intellectual disability usually have a history of developmental concern. Question: is decline in school performance recent and or a perpetual? Significant if a perpetual, consider pathophysiologic process such as vision or hearing impairment, side effect from medication, neurodegenerative disorder, or recent psychosocial issue. Question: past medical history, medication review system, psychosocial stressor. Significant: school attendance, illness versus avoidance, early development and behavior, family history of learning problem, sleep pattern, apnea, insomnia. Physical examination finding subtle dysmorphology. Significant may suggest presence of genetic disorder or pattern of malformation resulting from teratogenic fetal exposure, alcohol, phenytoin. Finding skin lesion significant may suggest underlying genetic such as tuberous sclerosis. Finding a large tonsil significant may cause sleep disturbance that affect learning and or behavior. Finding abnormal neurological examination significance, any focal sign demand additional evaluation, a slow, rapid alternating finger movement, a neuromaturational sign are often present in child with the learning disability but are generally not helpful clinically. Diagnostic test, physician, audiology and vision screening, standardized behavior questionnaire, teacher and parent Vanderbilt. Consider other screening tool for depression and anxiety, family dysfunction, parental depression and substance abuse, genetic, neurological evaluation if indicated by history and physical examination. Educator, teacher, administrate measures or computer administered tests to monitor progression. Standardized achievement test can be administered yearly to measure current functional and review progress. Psychologist, testing must be performed individually and include intellectual and academic functional at a minimum. University and hospital-based center outside the school system also conduct evaluation of children with learning disability. For children who do not respond to educational intervention or if the psychoeducational evaluation is inconclusive, a neuropsychological test may identify specific cognitive factors that are helpful in developing an effective educational plan. Conditions that may cause poor school performance or co-occur with the learning disability, hearing or vision problems. All children who are experiencing learning difficulty should be screened for sensory deficit. Sleep deprivation, sleep problems can cause inattention and irritability and contribute to poor school performance. Conversely, poor school performance and homework struggle may contribute to difficulty sleeping. Developmental problems, children with the overall intellectual or social limitation will learn more slowly than their age mate. Children with the low achievement and low intellectual level often have the same problem as children with learning disability. Attention deficit hyperactive disorder, children who are inattentive or impulsive may manifest poor academic performance. They may have problem with getting the work completed and turned in rather than a skill deficit. Conversely, children experience academic difficulties may seem restless and inattentive. Exposure to adverse childhood experience, children who have experienced or witnessed trauma, violence, natural disaster, separation from a parent, parental divorce or separation, parental substance use, neglect, or physical, emotional, or sexual abuse are at high risk of developing emotional difficulties such as adjustment disorder or post-traumatic stress disorder. Children with post-traumatic stress disorder can manifest poor concentration, memory problems, school refusal, and academic decline. These children may also manifest other forms of anxiety. Parents are often unaware of exposure that children may have had at school or in the community. There may be major trauma in the family, serious illness in a parent, maltreatment of a child, death or incarceration of a loved one that are similarly not discussed or disclosed. The three hallmark symptoms of a cluster of post-traumatic stress disorder are re-experiencing, avoidance of memories or situations that recall the trauma, and hypervigilance, like increased worry about safety, startling or anxious at unexpected sound or event. Anxiety. Children with anxiety may experience difficulty concentrating and perform poorly on tests. Bereavement. Most children will experience the death of a family member or friend sometime in their childhood. Other losses may also trigger a grief response, separation or divorce of a parent's, relocation, change of school, development of parents in military service, break up with a girlfriend or boyfriend, or a remarriage of parent. Such losses are traumatic. They may result in such symptoms as sadness, anxiety, difficulty concentrating, poor impulse control, or academic decline immediately following the loss, and in some instances more persistently. Depression may cause a decline in school performance or simply coexist with learning disability. Marked sleep disturbance, disturbed appetite, low mood, or tearfulness could indicate that a child, or more commonly an adolescent, is depressed. Conduct or oppositional defiant disorder. Physical illness. Medical issues that may have an effect on school performance include all illnesses that may interfere with the child's attendance. Some illnesses or symptoms caused by the illness can affect attention in the classroom, like hypo or hyperthyroidism, undiagnosed diabetes, or side effect of medications such as bronchodilator or anticonvulsant. Cancer treatment, HIV infection, lead intoxication, chronic malnutrition, iron deficiency, iatrogenic intervention. Neurological etiology, absence seizure and other non-convulsive epileptic disorder, neurodegenerative disorders such as Niemann-Pick disease, adrenoleukodystrophy, steroid lipofuscinosis, and subacute sclerosing panencephalitis may rarely present as school-age learning problems. CNS trauma, genetics disorder, many types of genetic disorder. Examples include 6 chromosome aneuploidy, fragile X syndrome, neurofibromatosis, tuberous sclerosis, velocardiofacial deficiency, Dagger syndrome. Substance use. Children frustrated with their school performance may use substances such as alcohol, nicotine, other drugs to alleviate their frustration, or self-medication with caffeine or cocaine. Conversely, children using substances may manifest in attention, impulsive, and deteriorating school performance. Autism spectrum disorder, including high functional autism, which was formerly known as pervasive developmental disorder, and Asperger syndrome. Children who have these difficulties also have problems with the social relatedness, poor eye contact, performance for solitary activity, language often stilted, and range of interest, persistent and intense interest in a particular activity or subject. They often will have very rigid expectation for routine and become anxious or angry if these expectations are not met, such as children may manifest difficulties in classroom and many of the symptoms associated with learning disorder. Thank you.